Okay, we'll go ahead and get started. Thank you for joining us today for session 3 in a 4-part session, the urea cycle disorders, Echo the Essentials. It's brought to you by the National Urea Cycle Disorders Foundation and the Urea Cycle Disorders Consortium. My name is Teresa Warner. I'm a parent of a UCD patient, and I'm also the executive director of the National Urea Cycle Disorders Foundation. Joining me today is Jill Williams. She's our deputy director. If you have any questions, she'll be monitoring the chat. At NUCDF, our mission is to save lives and improve outcomes of individuals with urea cycle disorders. We believe this 4-part series will move us closer to our goal to rapidly diagnose, effectively treat, and cure UCDs. The UCD Echo and CME credit is supported by the families of the National Urea Cycle Disorders Foundation. We want to thank you for your commitment today and for sharing in our mission. The QR code, let's go ahead and go to the next slide. This QR code, if you'd like to scan that, that'll allow you to sign into today's session. It is also in the chat. There's a link. If you have just signed in, if you'll put in the chat your name and where you're joining us from. And we'll hold here for about a minute to let everyone scan this QR code. Okay, next slide, please. Today's agenda, we'll have 5 minutes for introductions and housekeeping, a 60-minute didactic presentation by Dr. Nicholas Ah Mew and Erin MacLeod from Children's National Hospital in Washington, D.C. And then we'll end with a 25-minute group discussion. Next slide. Just a little bit of housekeeping, if possible, if you could make sure to keep your camera on. Echo is intended for educational purposes only. Presenters can and will not provide medical advice. To receive CME credit, please remain in the session and complete the evaluation form using the link that will be provided at the end of the presentation. Next slide. And you can go ahead and introduce yourselves in the chat. And next slide. Today, I'd like to introduce our subject area experts. We are thrilled to have Erin MacLeod. She is the Assistant Professor of Pediatrics and Director of the Metabolic Nutrition Clinic at Children's National Hospital in Washington, D.C. She's the past president of the Genetic Metabolic Dietitians International. Also with us is Dr. Nicholas Ah Mew. He's a Director of Inherited Metabolic Disorders Program at Children's National Hospital. He's the co-principal investigator of the Urea Cycle Disorders Consortium. He's also a medical advisory board member for the National Urea Cycle Disorders Foundation. And I will turn it over to them. And thank you.
Thank you so much, Teresa and Jill, for the opportunity to talk here today. I just would begin by sharing a few disclosures. So for myself, I serve on the data monitoring board of several clinical trials, including those conducted by Eacure and Arcturus, as a consultant to ongoing trials or planning of trials by Ultragenyx and Moderna. And Dr. MacLeod has participated in advisory boards for Amgen, previously Horizon. Next slide. So for today, what we'd like to do is discuss the primary principles of chronic UCD management. We'd like you at the end of this to be able to identify differences in management strategies for severe versus mild UCD cases, as well as recognize differences in management between different UCD diagnoses. And I would add here that we would like to do so by first explaining some very basic principles. Second, sharing with you a bit of an analogy of how we observe management in urea cycle disorders, how we think about them, and then finally, to go through several cases in which we describe our approach to management. We did want to get a sense of our audience, though, to begin with, and if you wouldn't mind using the QR code here to highlight how many patients you follow with a urea cycle disorder, just so we have a sense of whom we're talking with today. Maybe we'll just give 1 minute to do this as well. Well, I won't take too much time to do this. I see we have 7 responders so far. Thanks for doing that. So we have some folks who are very experienced and some folks who have limited experience in management. But so that's great. We're hopefully this talk will have a little bit for everybody. Um, so um, all of you are already somewhat familiar with the urea cycle. But I briefly want to go through some basic things about the urea cycle itself, as well as its management. We will discuss thereafter several cases. So as many of you know, the hepatic urea cycle converts ammonia, that is essentially waste nitrogen that comes from the breakdown of protein and amino acids into urea, which then we get rid of in our urine. And it happens to be that the liver is the organ that expresses all the enzymes and transporters of the urea cycle. And so a defect in any of the enzymes or transporters can cause a buildup of ammonia. Individual disorders have individual features, but as a whole, all of them can cause elevations in ammonia level. Why is ammonia bad? Well, so elevated ammonia levels can cause brain edema. Ammonia is taken up by the brain and is immediately converted into glutamine, which then causes swelling of cells called astrocytes, and the variety of downstream effects of that. And so this is what we're trying to ultimately prevent in these conditions. We'll share also some features of acute hyperammonemia here. Some of these were already discussed in prior sessions, so I won't go through all of them today, but all of which to say it's really important to be aware of some of the symptoms that you can get as a result of acute hyperammonemia, so that you can appropriately treat these conditions. Not everybody has the same degree of defect in the urea cycle, however, and residual enzyme activity predicts the age of onset in these conditions. In individuals or in individuals that present in the neonatal period, these typically are patients that have no urea cycle enzyme activity at all. On the other hand, if you have normal enzyme activity, we expect you to have absolutely no symptoms. But it's also possible that you have reduced but still present amount of urea cycle activity. And in that case, these typically are individuals who will present in childhood and adulthood with specific environmental triggers. So all of which to say that, there's no one-size-fits-all treatment to patients with urea cycle disorders, because the degree of enzyme activity can be different in different people. The treatment really needs to be individualized and tailored to a specific patient and their severity of the disease. So not only is it important to look at ammonia, but there are other compounds, there are other biochemical markers that we might want to look at. So as many of you know, the hepatic urea cycle, if it is working, the intermediates, or basically the substrates and products of the urea cycle, don't leave the hepatocyte. However, if there is a defect of some kind, then the metabolites upstream of the block can leave the hepatocyte and enter the blood. And those could be used for diagnostic purposes and potentially management purposes as well. And some of these metabolites, like arginine and argitosuccinate, may be toxic. And I would add that, that with specific conditions, that these elevations need to be addressed as well. We're not going to talk about those specifics. We're going to focus on sort of ammonia levels, but just to be aware that you may also need to be managing, for instance, arginine levels in individuals with arginase deficiency. So as highlighted, these urea cycle intermediates can be used for the purpose of diagnosis as well as management. I think this was already previously discussed in a prior echo talk. We're just highlighting here some of the amino acids that you would expect to be abnormal in each of the different canonical disorders of the urea cycle. And again, I won't go through this in detail, but ultimately it's here for your review. With respect to these first disorders, NAG synthase, CPS1, and OTC deficiency, there is an additional biomarker called orotic acid that typically is used diagnostically in order to be able to diagnose or separate those who have OTC deficiency between those who have NAG synthase and CPS1 deficiency. But it is not typically used from a management perspective. Another amino acid that's tremendously important in the management of urea cycle disorders is glutamine. And many of you may be familiar that glutamine can be elevated in patients with urea cycle disorders. And so I just want to explain why this is elevated and then how it later on is used in management. So when you eat protein, the protein itself is broken down in the gut and can be broken down into amino acids, and this can release ammonia. So ammonia from the intestines travels in your portal circulation to the liver. So this is where I'm showing blood from the gut on this slide. The urea cycle activity within the liver itself is not uniform. That the cells that are periportal, in other words, the cells that are there just where the portal circulation comes in, have the greatest urea cycle enzyme activity. And that's what I'm trying to highlight at the bottom here with that triangle. It's greatest in those cells that are in zone 1, the periportal cells. As the blood flows, however, through to the pericentral cells, those are the cells that have the ability or have a greater ability to form glutamine. So why is this important? It's important because if for whatever reason your urea cycle is dysfunctional, then more ammonia ends up going to those cells that are pericentral, and that ammonia is then converted to glutamine. But this process is limited. Unlike the urea cycle that is cyclical and can go around for a very long time, you can only convert so much glutamate to glutamine or so much, alpha ketoglutarate to glutamine. And so once you reach that capacity, then all of a sudden ammonia starts going into your system, right? So the reason I'm highlighting all of this is because high blood glutamine can reflect this excess nitrogen, the inability of the urea cycle to deal with this excess nitrogen, and has been shown in several studies that elevated glutamine is associated with a higher risk of hyperammonemia. So with that as a background, I want to highlight that these conditions are not just ammonia management, but management of these different amino acids as well. And essentially what we're trying to do is control the flow of nitrogen in the body. So typically the goals of long-term management will include, first, providing enough dietary protein for normal synthesis and growth. And we do this by monitoring things like, as I mentioned, glutamine, ammonia, urea cycle intermediates, and essential amino acids. Second, providing enough dietary nutrients for healthy living. And for this, you may need to monitor other essential nutrients. And lastly, we want to be able to prevent acute hyperammonemia, right? This is one of the most important things. And you may ask, how do we do this? Well, first, it helps to know what the triggers of hyperammonemia are. What are the things that can cause you to go into acute hyperammonemia? So some of them are shown here in this pie chart on the left. This 58% illness really represents infections of some kind. So these are often triggers of hyperammonemia, but also dietary changes, stressful events, as well as missed medication can cause hyperammonemia. Within that 7% other, I've included other reasons that you can develop hyperammonemia. I've made a category that includes prolonged fasting or any reason that you may be fasting for a long period. That may include having to be NPO for surgery, things like gastric bypass, or anytime during delivery or in the immediate postpartum period. These are all times where you may be asked to fast for a prolonged period and may be at risk of hyperammonemia. Changes in hormones caused by menses or puberty can also trigger hyperammonemia. And finally, in this other category, there are medications. Corticosteroids, we know, precipitate catabolism, can precipitate the breakdown of protein. This can cause hyperammonemia too, as well as valproic acid and chemotherapy that typically block the urea cycle and thereby causing hyperammonemia. So what can you do about all of these things? Well, here are some suggestions that we have and we think are helpful in preventing hyperammonemia. The first, with respect to acute illness, we provide many of our patients with an acute management plan. This basically will highlight what to do if a patient is sick or is beginning to have symptoms of elevated ammonia levels. This is available to them such that if they go to a local emergency department or even to our own emergency department, there are immediate directives as to how best to proceed. Second, we sometimes provide patients additional protein-free calories to prevent catabolism. Many of you may employ what are called sick day diets, and essentially this is the strategy here. It's just we're not calling it as such because we always want to make sure, at least for our own patient population, that they communicate with us with respect to what's going on and any changes that they may make in their diet. We'd rather, although it's important to empower patients and families, this is a scenario where we really want to be involved in the specific management. As we know, fever can increase your metabolic rate, and this is something that might be problematic in a patient that is perhaps not receiving sufficient calories. So we typically address fever very aggressively. And lastly, again, not to be very political here because it's a hot topic these days, but we do very much encourage immunizations for two reasons. One, it's very clear that these can prevent infections. And secondarily, there's good evidence and there are publications from the Urea Cycle Disorders Consortium that immunizations themselves don't pose an increased risk of hyperammonemia of any kind. In terms of avoidance of fasting, typically for surgery or delivery or things like this, we will recommend IV fluids that are dextrose containing throughout the procedure and sometimes before the procedure, so pre-admitting families and patients in preparation for the period of prolonged fast. And with respect to avoiding harmful medications, what we've opted to do at Children's National is have some kind of medical chart alert, have these medications like valproic acid and corticosteroids noted as reactions or allergies, such that providers taking care of those patients know to avoid those medications. We'll also make sure our patients have some kind of medic alert or equivalent bracelet or necklace that will indicate these as potential reactions. Some of these days have a QR code, so you can actually put in more information like acute management plan in them. But at the basic level, having some information about medications that should not be administered. So our next slide.
In addition to being mindful of sort of those acute times that you could have hyperammonemia, we also talk with our families about different high-risk life stages. So I have this picture here of a cliff because we often talk about how our patients are sort of walking on a cliff. Depending on what their glutamine is, at any point they could fall off of that cliff. And these are different life stages where they may be more likely to be, walking a little closer to that cliff. In the beginning, if we have a neonatal urea cycle patient, after that first presentation, they often go through what we call a honeymoon period. So that's actually a time that they are pretty stable and they're growing really well and they're able to tolerate a lot more protein. But then they sort of move into a toddler age. That is very difficult. As anyone who's ever dealt with a toddler, there's an increased illness risk, but there's also, difficulty in sort of explaining the importance of following a diet. And then as children get older, they have a prepubertal growth spurt. So this becomes a challenge because they've gotten used to consuming a certain amount of protein, but during this prepubertal growth spurt, their body is trying to grow really fast, and you need protein in order to grow. So they may actually require more protein than they're used to taking in, and this can be a real time of instability. And then we get through that prepubertal growth spurt, and then there's a post-puberty growth slowdown. So maybe they've gotten used to eating a little more protein, but now they're having hormonal fluctuations and they're not growing as fast. So this can be another time of instability. And then in the adult ages, if there is weight loss in and of itself is a catabolic process. So this can be challenging for our urea cycle patients. And then also pregnancy and delivery, there's a high protein demand and all of the risks that come with delivery. So these are additional times that we're trying to pay really close attention to our patients to avoid hyperammonemia.
So we want to introduce you to this analogy here of with respect to management of urea cycle disorders, and one we've used often is one of an overflowing bathtub. So the idea here is that you have a faucet that is producing ammonia, and that goes into your wash basin. Obviously, at the bottom of the wash basin, you have a drain, and in this case, the drain is the urea cycle. It is what is able to get rid of the excess ammonia that's there. Obviously, if you have a patient that has a urea cycle disorder, the idea here is that drain is a little bit more closed or clogged, not allowing as much of the ammonia to go through. Within the basin itself, you have a nitrogen pool. So that's not only the ammonia, but these different amino acids that we're talking about that you need, right? So you need to maintain some degree of level. However, if for whatever reason you have excess ammonia production, then it can cause this bathtub to overflow, and that's our analogy for hyperammonemia. So sort of with this in mind, we're going to share with you 5 different cases and go through the management using this specific analogy. Starting with this idea that, well, if you have a urea cycle that's not working really well, is there some drain, or is there something really quick that we can do to kind of get the urea cycle working? So in this particular example, this is one of a girl that was identified on newborn screening with an elevated citrulline level, and then follow-up labs on that particular patient showed also, again, elevated citrulline as well as a glutamine that was a little over 1,000. Ammonia levels were normal in this patient. And then this is a patient that was exclusively breastfed. And later on, it was found that this patient had 2 mutations in the ASS1 gene that causes citrullinemia. So as we talked about before, it's not just ammonia level that we're looking at. We're looking at a combination of other biomarkers that include amino acids like glutamine, but also the essential amino acids in citrulline and arginine as well. And so in this particular patient, we ended up supplementing this patient with some L-arginine, so some arginine. And this is one of these intermediates of the urea cycle. But in addition to that, we had her on an unrestricted vegetarian diet with protein amount between 2.5 and 2.9 grams per kilo per day between these ages of 18 months and 3 years. And on this, her glutamine ended up dropping from a little over 1,000 to under 600 micromoles per liter. Obviously, her citrulline levels remain elevated because that was the specific disorder that she has. So why did we supplement with arginine? I just want to explain that as well. So one way to explain this is that essentially when you have a metabolic pathway that is a cycle, like the urea cycle, if you have a block of some kind within that cycle, then it converts this cyclical pathway into a unidirectional linear path. So I've drawn this as such on the right-hand side here. When you do so, it becomes really obvious what happens if you don't supplement arginine. First of all, you can become deficient in arginine, and that's an amino acid that you need to build protein. But the other is that when you replace arginine, then it permits every single other step of the urea cycle to work, including ones that incorporate ammonia of some kind. And so this is why this particular patient likely improved, and her ammonia levels and glutamine levels improved with the arginine supplementation.
So then if you maybe try a little bit of Drano and that doesn't work, what's the first thing you want to do to prevent this bathtub from overflowing? And so one thing you can do is turn down the faucet. So in this scenario, we want to reduce how much nitrogen is going into the pool. And we can do this either through protein restriction, so limiting the amount of nitrogen going in, or promoting anabolism. So if the nitrogen is being used in the body elsewhere, it's then not going into the overall nitrogen pool. And one thing to keep in mind is that our bathtub typically has actually 2 different faucets, right? We have exogenous protein, so that's the protein that we're eating and the nitrogen that we're getting from our diet. And then endogenous protein. So when we're going through catabolism and we're breaking down protein, that is also a source of nitrogen into the overall nitrogen pool. And so first I want to talk just a little bit about some of the general basics around formula and the diet for urea cycle disorders. Thinking about medical food options, there are 3 different types of medical foods that one might choose to offer to a patient with urea cycle disorder. One is what we would call a complete essential amino acid formula. So this would be a formula that the protein is all of the essential amino acids, so the amino acids that our body cannot make on our own, but then also has calories through the source of fats and carbohydrates, as well as vitamins and minerals. Then there are some formulas that are incomplete essential amino acid formulas. These are medical foods that generally only provide the essential amino acids and may not have a lot of vitamins and minerals or additional calories. And then finally, many of these patients are on protein-free formulas. So these are medical foods that don't have any protein at all and are a source of non-protein calories. But when we think about diet in and of itself doesn't come without its risks. And so we always have to weigh the pros and the cons. Our goal in providing a lower protein diet for urea cycle disorders is to limit the nitrogen input, right? So to turn down that faucet and limit how much nitrogen is going into the pool. But there are risks that come with any sort of diet that you employ on someone. We know that if you don't consume enough protein, you're going to have linear growth depression. You're not going to grow as much as you need. There's a risk for micronutrient deficiencies. There's the psychological burden that comes with being on a diet all the time. And then cost and coverage for the special medical foods might be a challenge. And then making sure that we execute that diet in a healthy way. So these are all of the things that we have to think about when we're employing a special diet for a patient. Next, I'd like to talk a little bit about general protein needs for the greater population. So here we have a chart of different recommendations. We have the WHO recommendation for protein, the DRI or the dietary reference intake. And then here we also have the AMDR, and this stands for the acceptable macronutrient distribution range, right? Calories come from 3 sources. They come from protein, fat, and carbs. Together, that ends up being 100% of our calories, right? So this is a percentage that is recommended for what percentage of anyone's calories should come from protein. So when we think about that, and we think about an individual, if we take an adult female who is 68 kilos, based on the WHO, her requirement for protein would be a little under 48 grams of protein a day. But actually, if she were to be consuming that lowest amount of percentage of calories, the recommendation would actually be 50 grams of protein. This is even a larger discrepancy when we look at an adult male who is 80 kilos, and the WHO might say he only needs 46 grams of protein, but the recommended distribution range says that he should be getting 10 to 35% of calories, and 10% of calories would actually be 64 grams of protein. So this can increase the discrepancy and something to consider when we're talking to patients. In addition, we don't necessarily eat what the recommended, what the WHO requirements are. Here we have a typical American diet and typical intakes based on age. And the purple lines indicate what the WHO requirement is versus the bars, which indicate what typical Americans eat. And so saying that we can just put someone on the WHO requirement for protein is actually a protein restriction and is something that is going to need some counseling in order to do that in a healthful way. So how does this translate to protein goals for urea cycle disorders? So here I have a chart breaking down the two different sources of protein someone with a urea cycle disorder may be getting their protein from. So one source is EAA, that's the essential amino acids. So again, this would be a medical food that some patients with urea cycle disorders may require. And this is a medical food that the protein is only those essential amino acids. And then we do that in combination with natural protein from food. And that's how we then get our total protein goals. Now, how this distribution occurs is dependent on the individual and on their individual tolerance. And one thing to consider might be their diagnosis. So here I have a list of diagnoses. At the top, we have patients that tend to have the most restrictive diets, whereas at the bottom, the least restrictive. So you can see here, we have NAG synthase at the bottom because with the addition of carglumic acid, patients who have NAGs don't need a diet restriction at all while they're consuming that medication. Versus at the top, a neonatal OTC patient or neonatal CPS, it's going to have probably the most restrictive. So they're going to tolerate the least amount of natural protein and may require more essential amino acids in order to keep their ammonia under control. Underneath that, we have arginase. Arginase is a little bit different, and we'll talk about that later in the presentation. Citrullinemia is somewhere in the middle because there are some patients with citrullinemia who may have a neonatal presentation. In that case, they may have a higher restriction of natural protein, or like our previous case that Dr. Ah Mew talked about, a citrullinemia patient who is diagnosed on newborn screening may not require any intervention with diet with the appropriate medication. And so let's talk a little bit about this concept of turning down the faucet. So here we have another case example. This is another patient who had an elevated citrulline on newborn screen. When she was brought in for diagnosis, she had a citrulline a little over 1,000. Her glutamine was around 900. She was also started on arginine for that same reason that Dr. Ah Mew already discussed. But then she was also started on a protein-free formula in order to support her calories and her growth and offset some of those calories so that she wasn't consuming as much protein. And then as she got older, she was recommended a vegetarian diet, but with a certain amount of protein. So her goal was between 1.5 to 2 grams per kilo of protein. The family counted very high protein foods, but didn't necessarily count the lower protein foods. And so how do we employ this with patients? One thing we always talk with them about is not only the quantity of protein, but also the quality of protein and the composition. So in thinking about a vegetarian diet, many of our patients, our older patients, will go just to French fries. Well, if all of their protein is coming from French fries, that is not a good quality type of protein. So we talk about other sources of protein. And all of these examples here all have about the same amount of total protein and about the same amount of calories, but you can see there's a good amount of variety here, providing differing amounts of vitamins and minerals and good healthy fats. So we try to talk with our patients about diversifying their sources of protein. We also talk about other things to consider. So maybe alternating their grains, which all have different amounts of protein as well. Depending on the individual diagnosis, we talk about high arginine foods. So these are foods that we would avoid in patients that have arginase deficiency, but might be foods that we would encourage in patients that have citrullinemia who are already on an arginine supplement. In addition, there's high citrulline foods. And again, these are high, generally speaking, but these would not be a substitute for arginine or citrulline supplements. We also talk about vegetarian products. So when I first started at Children's, we, would easily say, oh, we'll just put them on a vegetarian diet and that will inherently be lower in protein. That's not necessarily the case anymore. There are so many different vegetarian proteins available that are actually comparable to their higher protein alternatives that we really have to educate patients on looking at food labels and understanding that just because it's vegetarian doesn't mean it's lower in protein. So with that, thinking back to our example 2, she continued on a vegetarian diet, but she started to have a preference for higher protein foods, even though the family was watching her portions really closely. And every time they came in and had a diet analysis, she was always, getting what was recommended. We would slowly try to turn that faucet down a little bit more, got her just to the DRI for protein, but you can see her glutamine continued to rise over time. We trialed some essential amino acid medical foods, but that was not desired or tolerated by the patient. And so what do we do in this scenario where we can't really turn down the faucet anymore?
So again, using this analogy, we want to introduce this idea of not using this native urea cycle drain, but using other tools, in this case, nitrogen scavengers, or some of you may know as ammonia scavengers, in order to be able to bucket water out of your wash basin here. And so what are those? Again, many of you may already be familiar, but there are 2 major categories, if you will, of medications, alternative pathway medications that are available. First is benzoate, and the second is phenylacetate. And these combine with these non-essential amino acids, glycine and glutamine, to form hippurate and phenylacetylglutamine, respectively. And these are compounds that you then pee out in the urine and allow you to get rid of additional nitrogen. Many of you may remember using phenylacetate itself as a medication, and it was very, very unpalatable. And so since then, there have been some alternative formulations of these in the form of sodium phenylbutyrate, which now you can have either in powder or in tablet form, or there are some taste mask formulations of this as well as glycerol phenylbutyrate, which is an oil. But ultimately, all of these compounds end up being converted to phenylacetate, which then combines with glutamine. The title of this talk is, the importance of diet. And in general, in terms of management, as we've highlighted here so far, we are typically a diet first medical team. We employ diet first, even before we consider these scavenger medications. And I do want to explain why. And part of this is that the scavengers, other than some other side effects that you could have or adverse effects that you can have from taking medications, the other thing is that they work stoichiometrically. In other words, a certain number of moles of your scavenger will only eliminate a certain amount of nitrogen. And I've done kind of like this back of the napkin math here. But as you can see at the very bottom, essentially, if you're on the maximum dose of glycerol phenylbutyrate, this would get rid of approximately 19 grams of protein worth of nitrogen, right? And so that's about the same amount as 3 eggs. And for the most part, most people can eat more than that. It would be very easy to eat way more protein than your scavengers would be able to get rid of. I would highlight here again, this isn't exactly how the body works. Obviously, these medications are not 100% effective in terms of eliminating nitrogen. Not all of your protein is necessarily metabolized immediately into ammonia. But again, all I'm trying to do here is to demonstrate the limitations of the medications themselves and why it is important, at least in any patient, to consider diet first. So we had done this specifically for the case that Erin had presented with, and we had, as you had seen, despite our best efforts to control, the dietary influx of nitrogen, glutamine levels remained high. In our group, we are very aggressive in managing glutamine levels for the reason that I explained, that we think that this is correlated with an increased risk of hyperammonemia. And so with that in mind, we started this patient on glycerol phenylbutyrate in order to be able to improve her glutamine levels, but as well as to increase her dietary protein tolerance. I want to share another case in which we also employed glycerol phenylbutyrate. So this is the case of a gentleman. Initially, I think he came to us in his 30s, but he had an uncle that presented with a metabolic crisis in his 60s. He had hyperammonemia and ultimately was diagnosed with OTC deficiency. And this resulted in cascade testing of the other family members, including this otherwise healthy gentleman who came to us. And at that time, his biochemical workup was entirely normal. His ammonia was normal. His citrulline level was pretty normal, as was his arginine. You know, he had his diet analyzed at the time as well as yearly. He had never had excessive protein intake. But unfortunately, he had a second uncle and I think a third uncle that ended up passing away from OTC, unfortunately. And so, you know, this is a scenario where he came to us in terms of, you know, regular follow-up as well as management. And so in him, we ended up following his glutamine yearly here. And as you can see, these were relatively acceptable. And I want to remind you why, you know, where glutamine comes from. Again, it comes from a scenario where your urea cycle is not working sufficiently well. Excess ammonia can then get to these pericentral cells that convert the ammonia into glutamine. So glutamine will only rise in a scenario where the urea cycle is not functioning sufficiently well. This was clearly a gentleman who was otherwise healthy. And even though he had a urea cycle disorder that resulted in symptoms in other individuals, he himself appeared to have numbers that were relatively stable and looked really well. So some of you may have opted to treat these patients with scavengers, and we did not at the time, and I just want to explain why this is the case. So this is a gentleman who is you know, near middle aged and was not growing, obviously, and not shrinking in any fashion, right? So he is in neutral nitrogen balance. And so his urea cycle at the time was able to sufficiently get rid of all of the excess ammonia, all of the excess nitrogen in him. And there were two studies that were done. The initial study that looked at the use of benzoate in 1914, but a follow-up study in individuals that had renal failure. In these individuals that are in neutral nitrogen balance, if you divert nitrogen away from the urea cycle by using these scavengers, then there's, you know, then these individuals, in order to be able to maintain themselves in neutral nitrogen balance, they actually just make less urea, right? So again, in an individual who's in neutral nitrogen homeostasis, if you remove nitrogen via that alternative pathway, then you're going to get a compensatory reduction in urea production. So in him, because his glutamine levels were pretty good, we opted not to do anything at that time. However, we ended up seeing a subsequent elevation in his glutamine as time went on. And, you know, he has OTC deficiency. We do understand, broadly speaking, that there is increasing mitochondrial dysfunction. OTC is a mitochondrial protein. And so we did not think that this is something that would autocorrect, that would fix itself, that we suspected this is something that would get worse over time. And as a result, it's at that time we made the decision to start this patient on glycerol phenylbutyrate, right? So we do not think he needed it earlier, but later in life, when his glutamine started to go up, is when we started to treat him. Now, I want to highlight some caveats to this. You know, this is a patient that lives in the Washington, D.C. area. He lives close to our hospital. We're able to monitor him very, very frequently. And so this is a decision that we were comfortable with making. I recognize that some of you may have very different circumstances, may not be able to get amino acids that frequently, may have patients that live very, very far. You know, and some of you may feel more comfortable saying, okay, I appreciate that he's really healthy, but I want this patient to have scavengers available to them just in case. I entirely understand that. We're just sharing our decision-making with this particular patient in the context of our current clinical practice. So we described these different scenarios of being able to, you know, turn down the faucet by, you know, restricting protein. We have these medications that we can use to be able to bail out excess nitrogen, but sometimes, you know, so the next option here that we might consider, and despite all our best efforts to do all of that, we might need to proceed with something more drastic, like a liver transplant. After having tried all these other things, like the Drano examples of arginine or carglumic acid, maybe despite all of that, we're still seeing metabolic instability of some kind. So I just want to share this particular case, and I think many of you also may be familiar with this type of scenario. This is a patient who presented in the neonatal period of day of life 4, who was lethargic and hypothermic and had markedly elevated ammonia levels, elevated glutamine, undetectable citrulline. Later on, we got a neurotic acid that was 0, and this patient was diagnosed. So we're fortunate to be in a center where we're able to get these relatively rapidly, but we, as a result of these initial labs, suspected a diagnosis of NAG synthase or CPS1. This patient received dialysis as well as IV aminol, in other words, IV scavengers, both phenylacetate as well as sodium benzoate. Because of the possibility of NAG synthase deficiency, we also started this patient on carglumic acid. After this initial stabilization, we then switched this patient to enteral sodium phenylbutyrate. These days, it's possible we would select glycerol phenylbutyrate, but that was not the practice at that specific time, or was not available at the time for that purpose. Of course, we'd started this patient on initially an IV arginine and transitioned them to enteral citrulline as well. And we'd started them on a diet that we ramped up progressively, but ended up at a point where we were giving 0.84 grams per kilo per day of protein from essential amino acids and another 0.85 grams per kilo per day of natural protein from pump breast milk. Ultimately, this patient ended up being diagnosed with this neonatal form of CPS1 deficiency, and we discontinued the carglumic acid. One other thing we did with this particular patient in terms of management is place a gastrostomy tube. And we want to highlight why we employ this sometimes. But a gastrostomy tube essentially is a tube that goes from the outside directly into the stomach. What it does is it permits consistent and adequate administration of diet and medications. And in our experience, in our patients, in particular those for whom we suspect might be very brittle, this may help prevent one or more hospitalization visits because it permits patients and families of having a way to administer the appropriate diet and medications in a scenario. This is particularly helpful in the case of infants or toddlers, who may not necessarily eat or take their medications when you ask them to do so. And then the other good thing about the gastrostomy tube or G tube is that they can be easily removed when they're not used anymore. And so when patients are older and maybe better able to comply with diets, you can just remove the tube and the site itself will heal. In our experience, we have not observed that there have been virtually no patients who have regretted putting in the G tube. And in fact, most patients, and particularly those who are brittle, those families are very thankful that they have this alternative method of delivering the diet and medications. So in this particular case, despite doing all of this, despite having a G tube access, et cetera, this patient continued to have labile ammonia levels during their hospitalization. At this point, we ultimately referred this patient for a liver transplant. Again, given the course and diagnosis, we suspected this would be particularly helpful to this patient. We had tried to send this patient home several times. Every time we had done so, even within the week, this is a patient that returned back with elevated levels of ammonia and symptoms of hyperammonemia. And so in the end, the decision was made to keep this patient hospitalized under as best an optimal metabolic control as possible until they were able to get a liver transplant.
Finally, we want to highlight one other case where we sort of called in the plumber. We want to do everything possible. This is another little girl who presented on day of life 3 to an outside ED. She had been noted to have difficulty in the hospital prior to discharge. She was sort of difficult to wake, but they did discharge her on day of life 2. But at home, the parents were actually unable to wake her on day of life 3. And so she came to the outside ED and had an initial ammonia of 700. At our institution, her peak ammonia was 956. You can see here her glutamine was over 1,000 or over 2,000. She had a citrulline of 6. She did have an elevated uric acid, and so she was diagnosed with presumptive OTC deficiency. Similar to our last case, she had initial stabilization after dialysis and IV Ammonol. She was also started on oral sodium phenylbutyrate. As Dr. Amew said, had she been born now, we likely would have started the glycerol phenylbutyrate, but she's a little older. She was also initially given IV arginine, which transitioned to PO arginine. Although we discussed doing a G-tube at that initial admission, the family chose not to, and so she was ultimately discharged at about 1 month of age with NG and PO feeds, about half and half between essential amino acids and protein from pumped breast milk. Early on in her infancy, she actually had a really great honeymoon period. So she had no other admissions until she was about 14 months old. We transitioned her to solids right around 6 months. That went really well. She explored lots of foods, was really interested in solids. But then when she turned 2, she started having more frequent admissions. With every admission, there would be a decrease in her PO tolerance and her PO intake. She first started to refuse solids and became more picky with textures. And then following an admission when she was a little over 2.5, she started having decreased formula intake. And so although the family had initially refused G-tube placement, these frequent admissions, really proved that a G-tube was needed, and she was also starting to decrease in her weight. And so they ultimately agreed to do a G-tube just before she turned 3. So that helped with the stabilization. She only had 4 admissions the next 3 years, but she continued to struggle with her PO feeding. She was on feeding therapy, but really made little progress and was ultimately 100% G-tube fed at that time. Her admission frequency really started to increase in early childhood at about age 6. This was due to multiple illnesses and starting school, and she had frequent emesis. And then there were also some social changes and challenges at home that resulted in some increased admissions. All during this time, the team would discuss liver transplant with the family as an option for treatment. And we often discuss this with families as sometimes you're trading one condition for another. And for this family, they had concerns about the operation itself, about her post-transplant care, and ultimately decided to stick with the condition they knew rather than, trade it out for a liver transplant, and they declined liver transplant. She was then seen for precocious puberty at age 9 and actually had 7 hospitalizations in the year leading up to her first period, which was at 10.5. Because of these this increased metabolic instability, we talked with the family about hormonal supplementation to either suppress or regulate her menstrual cycle. The family felt that wasn't something they wanted to do, and she was actually quite regular from the start of her menses. And so we discussed a diet alternative, so trying to increase her calories in the week leading up to her menstrual cycle in hopes that would improve her metabolic stability and keep her out of the hospital. However, she continued to have multiple hospitalizations, which seemed to coincide with her menstrual cycle. She had been maxed out on her glycerol phenylbutyrate, and so after a couple admissions, we added a medication. So we added that other nitrogen scavenger, sodium benzoate, to her daily management. So she was getting both glycerol phenylbutyrate as well as sodium phenylbutyrate, or as well as sodium benzoate. We also stopped giving her those extra calories because they didn't seem to be helping with metabolic stability. And we were seeing a pretty significant increase in her weight and wanted to prevent excess weight gain. And so since starting the sodium benzoate, she has actually been very stable and has remained out of the hospital for about a year and a half. She's become more active and is actually doing regular cheerleading and is doing really well. And so this case really highlights a lot of those high-risk life stages that we talked about earlier. She had a great honeymoon period and then became more unstable in the toddler years, and then again with hormonal fluctuations and puberty became more unstable. And so this really highlights those sort of different life stages that we really want to think about with patients.
So again, these are the 5 cases that we wanted to share with you today. We just kind of wanted to review again these management principles that we talked about. The first of which is turning down the faucet. How do we decrease the amount of nitrogen precursors? These will come in 2 forms, or 2 faucets, if you will. The first is the protein restriction, so reducing the amount of exogenous protein that the body's taking. But remember also the body has protein that it can break down. And so in order to prevent that catabolism, you need to make sure that you have sufficient calories, and you want to promote an anabolic cycle. We have medications that we have available to us in the form of nitrogen scavengers, sodium benzoate, as well as phenyl acetate or its various prodrugs. That these are medications that can help remove excess ammonia or excess nitrogen without using the urea cycle itself. And the last is we want to be able to maximize the urea cycle function in some way. We have some tools like carglumic acid if you happen to have a responsive disorder, but also arginine or citrulline that can help the urea cycle, rev the urea cycle, and make it work a little bit better. Unfortunately, despite everything, if you're doing all of that, sometimes a liver transplant, in other words, a way to kind of replace this drain is what you need to do. And finally, on the horizon here, there are other treatments like gene therapy or gene editing that may hopefully become available in the near future to UCD patients, and you'll hear a little bit more about that at the next ECHO session. We wanted to end here with a couple of exceptions. And so just to highlight how some of the following disorders are perhaps a little bit different in which either the typical management or the typical episodes of hyperammonemia may not be key components of the disorder, or may not be everything in terms of managing these conditions. The first is citrin deficiency. This is as a result, or this is caused by a defect in a transporter, the SLC25A13 transporter. While it is associated with hyperammonemia, it's really important to note that its specific management will counterintuitively involve a high protein diet, right? A high protein, high fat, low carb diet, and that's very unlike the other urea cycle disorders. You may also be familiar with arginosuccinate lyase deficiency, or ASA or ASL deficiency. And not all individuals that have this specific condition will have hyperammonemic episodes. Nevertheless, you can still have developmental delay even without these frank episodes of hyperammonemia. We also know as a result of this condition that you can be at risk for things like high blood pressure or liver disease. That one of the questions that still needs to be worked through is whether protein restriction is really important for patients with this disorder, even in the absence of recurrent hyperammonemia. Another disorder in which you don't always get obvious or elevations in ammonia is arginase deficiency. Again, in this condition, ammonia and glutamine may not necessarily be high, but arginine is going to be markedly elevated. And it's as a result of the very elevated arginine as well as elevated guanidino compounds that you get some of the manifestations of this condition that can result in things like peripheral neuropathy. And so the management goal in this disorder is not only to control ammonia levels, but also to control arginine levels with diet as well as medications. And this is often very difficult to achieve without significant natural protein restrictions. And it's really important to consider the arginine content of some of the proteins that these patients might be taking. Maybe Dr. MacLeod can add a little bit more about that.
And so, as I mentioned earlier, these are some of the most restrictive diets. And my patients with arginase deficiency are on a very small percentage of protein from natural protein, and most of their protein is coming from essential amino acids. So that's different than the other disorders that we spoke about, but also the amount of arginine in certain proteins is different. And so, for example, pea protein is very high in arginine compared it to other like animal proteins. And so although someone may think, oh, as a arginase patient, I should be on, a vegetarian diet. And so something with pea protein that's a vegetarian protein must be better for me. That would actually be worse than having, a different high biological value protein. So thinking about the specific source of amino acid or of arginine in this scenario is the most important versus all of the other urea cycle disorders. We're talking about nitrogen and protein as a whole. Here, we want to think about the single amino acid arginine by itself. And then finally, we just have a few other final considerations for urea cycle patients. The first is to remember that food is not the only factor, right? In order to build protein, we need to consume enough protein. And if we're consuming protein, that helps us to build protein as well. And so we do want to encourage safe activity in our patients and hope that they are able to meet the activity goals for the general population. So I have that here, both for the general public, but also for individuals with disabilities, because we believe that as patients are more active, that will help to improve their metabolic stability. It may also help to improve their protein tolerance. Again, they're moving and they're building muscle, and so they need to therefore consume protein in order to help build that muscle. And then that will also help with their overall functional fitness and energy utilization as well. Another really important factor is hydration. So water is essential for the optimal enzymatic processes within the urea cycle, but then it's also important to help eliminate ammonium ion and the products of the nitrogen scavengers themselves. And so ensuring that our patients are well hydrated is really important. And also keeping in mind that an individual with a urea cycle disorder likely has a lower than normal BUN, right? BUN stands for blood urea nitrogen. So many times our patients with urea cycle disorders may have a normal BUN of 2 or 3. And so when they come into the hospital and their BUN is in the normal range, for them, that might actually indicate dehydration. And so a little different than the typical individual where you would expect dehydration to have a very high BUN. In these patients, a normal BUN may indicate dehydration and may require additional hydration for that patient. Finally, we have some resources here for you. Of course, the NUCDF is a wonderful resource. Also here is the website for the Urea Cycle Disorders Consortium. GMDI, Genetic Metabolic Dietitians International, has wonderful resources for different diseases, including urea cycle disorders, as well as the general gene review for urea cycle disorders, but then there are other gene reviews for the individual disorders. There's a guideline here out of the European guidelines, and then hopefully coming at the end of this year to beginning of next year, GMDI has been working on UCD nutrition guidelines specifically, and those should be out in the next year. And so at this time, we'd like to just open it up to any questions that you may have about the cases we presented here, or if you have your own case that you would like to discuss with the group, we would welcome those discussions as well, and any other questions you may have.
I just wanted to bring up one initiative that NUCDF is sponsoring for the month of October. It is Check Ammonia Month. You can find all the details at checkammonia.com. If you are a physician or have a clinic and you'd like some resources, if you would like to reach out to us, we will put some in the mail for you, and we'll have a full social media campaign and lots of resources on our website. Next slide. I want to say thank you to Dr. MacLeod and Dr. Ah Mew. This was a fantastic presentation. I think that there is a lot to gain here, and this is that missing component to really optimizing the understanding and the care of all patients. If you're on the call today, please share our echo. There is a QR code that you can scan to do the evaluation for your CME points. We have another echo. It's the last one for this year, and it'll be on November 11th. And it's going to build on this presentation with long-term management, and that's with Dr. Laura Conzel. So we hope to see you back and to spread the news. And if there is any final questions, you can put those in the chat, but you could also reach out to us anytime, and we will let you know when this video is live on our website so you can share the resources. And thank you so much again. We really appreciate it.